Is that B, D, E? Or you want to discuss all? Can somebody tell me? Answers, right? In a term asphyxiated infant, poor neurological outcome is indicated by EBGA score of 3 at 1 minute of age. Is it correct or wrong? Is it correct? This is a true or false, I think. MCQ is true or false. EBGA score at Chamaran, what do you think? Somebody has to talk. Come on. Can you all hear me?
Yes, madam.
All right. So can somebody tell me the answer for the EBGA score of 3 minutes at 3 at first minute of age? Is it true or false? So what does it mean? Is the EBGA score of 3 at first minute of age, is it unusual or abnormal? If you don't talk, I'm going to stop. Right? This is a discussion. Right? This is not a lecture.
It's true, madam.
Is it true? So no, it is not true, because EBGA score usually, the neurological outcome, the EBGA score usually EBGA score at 10 minutes is the parameter that we usually take. EBGA score at 3 minutes at first minute of age, the outcome, even with a very low EBGA at first minute of age, the outcome is not that bad, right? Because you know the baby just born, and EBGA score at 3 minutes first minute means maybe the baby is not breathing, maybe it's flu and all, but at the age of first minute, so the hypoxia is not that prominent to cause cerebral damage. If it lasts more than 5 minutes, usually what they say is that 10 minutes, and for the better sort of a prediction is usually taken at 10 minutes of age. EBGA score, if the EBGA score is low, below 5, at 10 minutes of age, then it indicates a poor neurological outcome. EBGA score at first minute of age, even with a low EBGA, the neurological outcome is, you can't predict the neurological outcome most of the time. With the studies have shown, EBGA, very low EBGA score at first minute of age, the outcome would be good, right? So EBGA score at first minute of age has no value in using to find out the neurological outcome in the later life, right? So that is wrong. Poor milk sucking in first week, is it true?
Yes, madam. Due to hypoglycemia, it can cause.
Here, no. This thing is different. If you find a baby who is not sucking well, poor milk sucking in first week, it is not due to hypoglycemia. Actually, a baby who is born asphyxiated. The term asphyxiated. So here in the stem it says the baby is already asphyxiated, right? If an asphyxiated baby who is not sucking in the first week of life means what? The child has had, what is the there are 3 grades of ischemic encephalopathy, no? Hypoxic ischemic. Yeah. So poor sucking is a type 1 or 2 or 3. HIE, hypoxic ischemic encephalopathy. If a baby is not sucking well, what does it mean? The hypoxic ischemic encephalopathy is usually grade 2 or 3, isn't it? So a baby who, the asphyxiated baby who is not sucking well means the child's, the neurological outcome is poor. Right? Understood. So this child has already got hypoxic ischemic encephalopathy, probably grade 2 or grade 3. Right? So that's how we can say this child's outcome is poor. And hypoxic ischemic encephalopathy type 1, do you know the signs and symptoms of hypoxic ischemic encephalopathy type 1? There the child is usually irritable, right? The sucking is not compromised, right? And so there's no convulsions, right? So that is HIE1. So you better just go through these symptoms of HIE1, HIE2 and HIE3. So HIE2 and 3, the neurological outcome is bad, but hypoxic ischemic encephalopathy grade 1, the outcome is not that bad, right? Poor you can't say HIE1 has a poor outcome, neurological outcome. Next question, peripheral cyanosis. Is it true or false? Yeah, false. Peripheral cyanosis doesn't mean anything. It only means that the child is having a little bit of a hypothermia, right? So it doesn't give any, even the asphyxiated baby, peripheral cyanosis has no no place, or it is not, the peripheral cyanosis does not indicate the poor neurological outcome, right? Hypocalcemia. Is it true or false? Do asphyxiated babies tend to get hypocalcemia?
Yes, madam.
Yeah, hypocalcemia is a complication of birth asphyxia, right? It can lead to convulsions, right? But you know the hypocalcemic convulsions does not cause cerebral damage. It's a very known fact. Hypocalcemia can cause convulsions, and asphyxia can lead to hypocalcemia. That's why the asphyxiated babies, usually we start calcium gluconate drip on day 1. Usually calcium is not replaced on day 1 in a baby, but severely asphyxiated babies, we give calcium from the first day of life, right? So hypocalcemia causes convulsions, but those convulsions does not lead to, hypocalcemic convulsions does not lead to poor neurological outcome. Okay, so how the hypocalcemia is wrong. What about the STEM E? Symptomatic hypoglycemia.
True.
True.
That is true, yes. Anyway, we know hypoglycemia causes neuroglycopenia, which lead to convulsions and symptoms. So neuroglycopenia causes poor neurological outcome. So asphyxia per se causes hypoglycemia. It leads to convulsions as well as poor neurological outcome. So here the answers, the false, true, false, false, true. Okay. Any questions regarding this, around this question? So try to read around these questions and gather more information, right? So here it's covered the birth asphyxia, the complications of birth asphyxia, and the factors leading to poor neurological outcome. Right? So intraventricular hemorrhage, birth asphyxia, another complication is intraventricular hemorrhages, which can lead to hydrocephalus and poor neurological outcome. Right? So think about other complications of birth asphyxia and the factors affecting the poor neurological outcome. And that's how you learn around the MCQ. So shall I move to the second one?
Okay, madam.
Yeah. Yeah. Can everybody see the question?
Yes, madam.
Yeah, okay. Read the question and let me the answer. This is a best response question. In this question, right, what are the key words here?
Ill-looking, febrile,
fever, right?
cough and fever for 6 days.
Yeah. And
Ill-looking,
yeah.
febrile,
Yeah.
hemodynamically stable.
Yeah.
AR entry is reduced in right lower zone. Few crackers. 2 centimeter liver enlargement and tip of the spleen also palpable.
Okay, so this is a child with pneumonia with hepatosplenomegaly. Yeah, so there's a systemic involvement as well, isn't it? Right?
Yes.
So, and then investigation shows what? WBC, there's a lymphocytic
Not
predominance. Yeah, and a little bit of a low platelet, and the CRP is 48. So this is a child who had a systemic involvement in addition to the right lower lobe pneumonia. So what is the most likely organism here? First, we'll try to exclude things. This is a single best response, right? So just go through the sentence and try to exclude things first. So could this be hepatitis B?
No, false.
Could this be glandular fever?
Yes.
Can, because of the hepatosplenomegaly.
Because, yes.
And what about getting pneumonia in glandular fever? Is it common to occur? Epstein-Barr virus.
Yes.
What is the possibility of having a pneumonia with glandular fever? Is it common thing?
No, it's not a common thing.
I will leave it. Right. Okay. Could this be Streptococcus pneumoniae? Lymphocytic predominance. In addition to that, the hepatosplenomegaly is not a usual presentation, isn't it? Yeah. Yes. Viral pneumonia?
False.
Yeah, very unlikely because usually viral pneumonia causes what? Bronchopneumonia and lobar pneumonia. So now we are left with what? Glandular fever and mycoplasma pneumonia. Right? Out of those two, what do you think is the most likely diagnosis?
Mycoplasma pneumonia?
Yeah, mycoplasma pneumonia, because that's common, right? And then usually the mycoplasma pneumonia, you can get anything, any kind of a systemic involvement, arthralgia, right? And hepatosplenomegaly, hemolytic anemia, right? So it's a 5-year-old boy, right? If they sometimes in these questions, the whole question is not there, right? Maybe this looks like a community acquired pneumonia, right? And with a systemic involvement and low platelet and lymphocytic pyramid and normal count, right? All are suggestive of mycoplasma pneumonia, right? We excluded hepatitis B, streptococcus pneumonia, and viral pneumonia at the beginning, right? The glandular fever also, if in severely immunocompromised children, you get the bronchopneumonia rather than lobar pneumonia, right? Here, the two organisms which leads to commonly cause lobar pneumonia are mycoplasma pneumonia and streptococcus pneumonia, right? And those two, out of those two, because of the lymphocytic predominant and the low platelet and with the systemic involvement, the mycoplasma pneumonia is the most likely diagnosis, right? So if you are not familiar with mycoplasma pneumonia, the other systemic involvement and systemic signs, just write it down and read it down. Read it today, right? Okay, that's how you go learn around MCQs. Right. So again, a true or false question. Drooling of saliva can be seen in. So drooling of saliva can be seen in. So just think about the anatomy and physiology, right? So what are the reasons for the drooling of saliva? There are a lot of causes in the pathway, but we'll go through upper motor neuron facial nerve palsy.
True.
How does it cause drooling of saliva? Can you explain? Does facial nerve palsy causes drooling of saliva? Drooling of saliva may be due to inability to swallow, right? Or excess production of saliva, isn't it? Right? So most of the time, you know, we all of us are producing saliva all the time, but we get used to swallow it without any problem, right? Okay, so conditions where the inability to swallow is the commonest cause for this drooling of saliva. So facial nerve palsy, especially upper motor neuron, facial nerve palsy, not the lower motor neuron lesion as well. Does it cause drooling of saliva?
Yes.
Yeah, can you explain how? It's not, right? Facial nerve palsy, there's no weakness of swallowing muscles at all, right? Okay, so it doesn't cause us swallowing problems.
Madam, weakness in the facial muscles, then they can't hold the saliva inside the mouth, so they can drooling of saliva
Especially
can
the ocularis oris muscle, because there is an inclination of the cone of the mouth toward the downwards,
but still, right? So there's no problem in the swallowing. We are not holding so if the swallowing is affected, only that there's drooling of saliva. Does facial nerve palsy causes drooling of saliva? Have you ever seen?
Yes.
Have you ever seen? We'll discuss. We'll ask from somebody also. In my opinion, it's strong, right? Okay, we'll discuss it again. I will just check it with somebody, right? What about cerebral palsy? Is it true or false? True. Why?
True.
Why is that? Because of
the oropharyngeal muscle paralysis.
pseudobulbar palsy, right? Because of the pseudobulbar palsy, that means the nuclei which are situated in the bulb area, right, can lead to the upper motor neuron lesion. That's why pseudobulbar palsy. Yes, definitely they can get a swallowing difficulty and drooling of saliva. So epiglottitis,
Yes.
True.
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 Fish bone stuck in retropharyngeal space. Yes, definitely.
True.
Again, there is a problem in the deglutition, difficulty in swallowing. That is true. Your question is, if it occurs at 6 weeks of age, need to get an action. Is it true? It's wrong, right? So why we don't have drooling of saliva? We unconsciously we swallow all the saliva which comes to our mouth, right? So usually the children would be getting that ability by the age of 8 months, right? When they are able to see in a seated down position, only they start to swallow the saliva, right? Till then, the drooling of saliva in a baby, otherwise normal baby, right? Okay. You don't consider it as abnormal. Understood? Right? Till the baby is sort of can maintain the upright position. That means when the baby can sit without support, right? Only the child starts swallowing the saliva, right? Till then they can't do that, right? Then you will see the drooling of saliva in little babies. Neurologically otherwise normal babies, this term is not correct actually, right? If it occurs in a neurologically normal child at the 6 weeks of age, need to get an action, right? This term is not written properly. Even with the cerebral palsy, you can get that solving problems. In that case, it's abnormal. But in an otherwise normal child who is having drooling of saliva below the age of 8 months, right? It's normal. Any questions? Anything you want to get clarified? No. It's not a sort of not a red flag sign, right? So the babies, some babies take some more time to learn that, right? That's a kind of it's not learn process, but it's a anyway. So they have to be in the seated position, upright position to swallow saliva. And some babies, it will take some more time to disappear this drooling of saliva. Usually by the age of 8 months, right? And we see some babies who are about 9-10 months also having drooling of saliva, right? Okay, so those babies, what we ask mothers to give something to lick, right? Or some sour things, so then they get used to swallow the saliva, right? So 8 months is not a red flag. Drooling of saliva at the 8 months of age, after 8 months of age is not a red flag sign, right? But usually they gain that ability by the age of 8 months when they are in the upright position. Okay. Anything else to be clarified? Right. Absence seizures. Here the most of the things are easy. I think you want to get clarified the same D. Am I correct?
Yes.
Yeah, absence seizures common in males, correct? No, 60 or 70%, I think. I can't remember the exact figures. The males, those are anyway very basics. Can be induced by hyperventilation. Has a characteristic ECG pattern. Is it true?
Yes, madam.
Yes, madam.
What is the characteristic ECG pattern?
3 hertz,
spikes and wave. Yes.
spike and slow wave.
So wave. Characterized by muscle hypotonia. Is it correct or wrong?
False.
False.
False. But do they get hypotonia? Can they get hypotonia?
Yes, they can.
Yeah.
Usually in the periorbital region and the eyelid and the limbs myopathy.
Yes, at the same time, you know, there's one category called atypical
Atypical.
abscesses, where you get the head drop, no? So then you get hypotonia. But in this question, it's clear, it's stated is absent seizures, right? So absent seizures, when it says characterized by, it is wrong. Okay. In absent seizures, rarely you can get muscle hypotonia. If it says like that, right, it's correct. But here it says characterized by muscle hypotonia. So that's false, right? In atypical absent seizures, you get hypotonia of the neck muscles, right? But here you can't say you can take it as true because it's not characterized by muscle hypotonia. Has better prognosis compared to other seizures, correct or is it correct or wrong?
Correct.
Correct. It's correct. The outcome is good. Right? It's correct. True. Right. This question, of course, I think not clearly written. Right? Because the information which is given in this thing is not enough to come to the conclusion. Anyway, we'll go through. A 3-year-old child who is not vaccinated against measles developed a rash involving face, arm, and so on. His brother developed chickenpox 3 days ago. What is the most likely diagnosis for his rash? Right? This information not enough to say. I think in this question, I would guess that they want the answer of Coxsackie virus. But nobody can say, right? I don't know why they have put the child has not got the measles vaccine before, right? To mislead you probably, right? Just because the rash involved in the face, palm, and soles, you can't say it is only the Coxsackie virus, right? So there's a contact history of chickenpox also 3 days, but 3 days is not enough to develop varicella zoster infection for the particular child, right? Because that may be the reason. I think it's not clearly written, right? So brother developed chickenpox 3 days ago. That means though the child has contact history, but there's not enough time to. What is the incubation period for chickenpox?
7 to 10 days.
7 to 10 days. 3 weeks actually. Can go up to 3 weeks. So only 3 days. So it cannot be varicella zoster, right? And then the rash only involves the face, palm, and sole. So it's very likely it's a Coxsackie virus, but this question is not a good question, right? Probably some information here is missing or the way it is written is wrong, right? But you have to think like that. So here the rash, they have not mentioned what sort of a rash, whether it's a maculopapular rash or vesicular rash, right? Okay. So varicella zoster usually causes vesicular rash, which start appearing the rash in the trunk. Measles causes a mobiliform rash, which is associated with fever. On the 3rd day, with the high spiking fever, only they developed maculopapular rash, which appears behind the ears first and then spread to the neck and then to the body. Coxsackie virus, right, causes hand, foot, and mouth disease, and it's again they can present with high-grade fever with a vesicular rash. Rubella again causes mobiliform rash, which the rash appears with the fever with a severe it associated with the tender cervical lymph nodes, right? The distribution is more or less the same, but it's the distribution, but the way of distributing the rash at the beginning is different in measles than in rubella, right? So in this viral exanthems, the best thing is for you to have a natural history, right? So measles usually causes this morbilliform rash with the high spiking fever, right? Most of the other viral exanthems, the rash appears after disappearing the fever. That's how you differentiate measles from other maculopapular rash or other viral exanthems, right? The distribution is important, the appearance, which day the rash is appeared, and how the rash is distributed are important factors to come to the clinical diagnosis, right? So the fifth disease, sixth disease, right? All these more the different diseases, right? The appearance of rash is different in different. It's different, right? Therefore, remember that always in the viral exanthem, the site, the distribution, the appearance of rash in relation to fever is important. Any questions on this? Shall I move to the other next question? Right. Features which favors non-minimal change nephrotic syndrome are heavy proteinuria, true or false?
False.
That's false, right? So to say it's a minimal or non-minimal, there's proteinuria has no say, right? Okay, so that means proteinuria is not a feature of non-minimal change. Right? Hypertension, is it true or false? These are a tricky question, right? Hypertension is a feature of minimal change also, but persistent hypertension or hypertension at the beginning, right? Or malignant hypertension or persistent hypertension is a feature of non-minimal change nephrotic syndrome, right? But even with the minimal change nephrotic syndrome, you can get hypertension during the course of the disease, right? Okay, so it is not a sort of a persistent feature, right? It's not there for all the time, but in the same it says persistent hypertension or hypertension at the beginning, at the outset, the onset, then it's a feature of non-minimal change. I think there's a problem in the question, right? Right? But here I would mark it as correct, right? Okay. Hypertension. Macroscopic hematuria, true. Features which favor non-minimal change nephrotic syndrome. Macroscopic hematuria. That's true. That is true. Hematuria, whatever the form, whether it's a macroscopic or microscopic, right, is a feature of non-minimal change, right? Then steroid resistance.
True.
That is again, steroid resistant is a feature, or steroid resistant is a feature of non-minimal change, right? Okay, it's true. Steroid resistance means, what does it mean steroid resistance means? You have to treat the patient for 28 days and see the response. If the child is not responding after the 28th day of correct dose of prednisolone with a good compliance, then you say it's a steroid resistant, right? The minimal change nephrotic syndrome, if the child, now we say it's a steroid sensitive nephrotic syndrome, right? So if the child responds to steroids very quickly and properly, then sometimes we don't do any other investigations to say this is a minimal change nephrotic syndrome. If the child has a resistance to steroids, right? Steroids, then we call it non-minimal change nephrotic syndrome. Steroid resistance is equal to non-minimal change nephrotic syndrome most of the time, right? Okay, so that is the answer is true here. Hyaline casts, true or false?
False.
That's false. Hyaline cast means when there's proteinuria, you get hyaline cast, right? Whatever the red cell cast, of course, a feature of non-minimal change, right? Not the hyaline cast. Any things to be anything you want to clarify on this question? Okay, I'll move to the other.
Madam,
Yeah, okay, go ahead.
is microscopic hematuria a feature of non-minimal change?
My hematuria is a feature of non-minimal change, but very sort of, I don't think in your level we won't ask that, right? In minimal change nephrotic syndrome, you might see a microscopic hematuria sometimes, right? That's sort of a postgraduate stuff. We will never ask that thing from you, right? Microscopic or macroscopic hematuria is a feature of non-minimal change nephrotic syndrome. But remember, in minimal change nephrotic syndrome, sometimes you might see very occasional microscopic hematuria. Okay, so don't get, but for y'all, presence of hematuria is a feature of non-minimal change nephrotic syndrome or secondary cause of nephrotic syndrome, right? Okay, keep that in your undergraduate level, that would be enough. For pediatrics, I don't know in medicine. All right. Okay, shall I move to the other one? Primary nocturnal enuresis. Common in female than in male. True or false? What is
False.
false? Males, it's common among males, isn't it? Associated with psychological stress.
True.
It is true. Yeah, what they say is usually that sometimes it appears when the second baby is born, right? When there is another member is in the family, the elders would get this, right? So primary nocturnal enuresis is anyway is the, yeah, that is true, because primary nocturnal enuresis, how would you define that? There is no bladder control at all after the age of 5 years. There is no dry period more than period of 6 months, isn't it? So that is true. Even a psychological stress is a known factor for primary nocturnal enuresis as well, right? Okay. There are a lot of causes. So what is the commonest cause? Is immaturity of the brain. And what would be the next? Right? You had a lecture on enuresis, isn't it? Right? Psychological stress is a known factor for primary nocturnal enuresis. What about neurogenic bladder? Is it true or false?
False. It's
Yeah, so it's false. Detrusor instability?
false.
False. Usually detrusor instability occurs in adults, not in children, right? Okay, but what they say is in constipation, sometimes they get a detrusor instability and which can lead to primary nocturnal enuresis, right? So don't get confused. This is primary nocturnal enuresis means the child had not been dry more than 6 months, right, since birth. The secondary nocturnal enuresis means child had been dry more than 6 months and then developed the bedwetting again, right? So associate with constipation, is it true or false?
True.
That is true, right? That is true. But remember, when a child who presents with primary nocturnal enuresis, you got to examine the spine to see whether there is a evidence of spina bifida occulta, right? But he is obviously a neurogenic bladder. It's a straightforward thing. I would mark it as wrong. But spina bifida occulta, you got to exclude when you're seeing patients with primary nocturnal enuresis. Right? Okay. So the commonest cause is immature brain immaturity, and the other thing is the insensitivity to ADH hormone, right? And these are the other causes are the which are here in this list, right? Constipation and psychological stress and so on. Any questions? Any clarifications? Okay. So can everybody read this question and let me know the answer? This is the best response, isn't it?
Assess compliance.
Why is that?
Because her TSH level is 15 and T4 is 2.6. Usually TSH gives us the idea about taking drugs every day. But T4 is the one who is actually is in the blood. As she is living with her grandmother. Grandmother had given the drug before coming to check the thyroxine level.
Exactly, yeah. So TSH is the best indicator to find out whether they have been taking the drug properly. No? So the T4 is normal because the previous day and probably on the day of checking the blood, they have taken the correct dose of thyroxine, right? So, but TSH indicates a child is not taking it properly and regularly, right? So we have to assess the compliance first. That's true, correct. So what is the answer for this? What is the answer?
Methotrexate.
Why is that? Yes, here this child, yeah. Okay, go ahead, yeah.
Because she is having polyarticular JIA. Now she is on high dose of ibuprofen. So we have to give methotrexate as DMARD because there is another option giving intraarticular steroids. But in this case, as she is having polyarticular JIA, we can't give for every joint that steroid. So it is better to give methotrexate.
Yeah, that's a second line drug anyway. So high dose of ibuprofen, how long you have to wait? Suppose this child has been diagnosed recently and you have started ibuprofen about a week back. What will you do? Change NSAIDs to nitronic sodium. Do you do that? Suppose this child had
No.
had this drug for about 1 week. How long you have to wait to see the response for a particular drug in
2 weeks.
Ideally, it's for 6 weeks, not for 2 weeks. 6 weeks in arthritis, in JIA, arthritis, right? You have to wait for 6 weeks to see if there's a good response or not. Then only you change over to another drug, right? Okay.
Okay.
So then we don't change this over to the diclofenac sodium, the same type of drug, right? Therefore, there's no place for the sodium, diclofenac sodium here. We don't start antibiotics because of the polyarticular JIA. We don't use intraarticular steroids. Systemic steroids is the last option. The disease modifying drug, the methotrexate, is the drug of choice for this kind of children. Here, the ideally stem should say that stiffness, even though she is on high dose of ibuprofen for more than a month or so, right? So ideally, you have to tell the duration also. Suppose you have started this ibuprofen 2 or 3 days back, you don't do anything. You wait and see, right? The duration is important. Again, another question on right? A 12-year-old boy present with bedwetting from his birth without dry period. That means again the primary nocturnal enuresis. No abnormalities were found on physical examination. And it's very important to examine the lower limbs and the spine to exclude any spinal. So basic investigations are normal. And what is the next step in the management? What is the percentage of children at the age of 12 years having nocturnal enuresis? Usually, 5% of children would be getting the bedwetting at the age of 12 years. When 1% of children at the bedwet at the age of even 15 years. Right? What I would say is I would again go ahead with a motivational therapy. I won't start any treatment. Right? But remember, right? If this child is severely distressed and upset and all because he's big now, you can use what? What is the other therapy? The best therapy? Desmopressin tablets, right? It's available and it's very expensive, right? And but it's available, right? You can treat primary nocturnal enuresis with desmopressin. This is, I think, it's easy. Why do you want to get it clarified?
Big.
What is the answer here?
B.
B. Why do you say it's B?
It's not B, madam. It's hump-nosed viper.
Yeah, it's hump-nosed viper. Severe local reaction with a normal whole blood clotting time, isn't it? Severe pain. Right? Severe pain. Usually the hump-nosed viper is the snake that causes this kind of a severe pain with a normal bleeding whole blood clotting time. Right? Okay.
Madam, we were confused with the cobra.
Why?
Because we read in a book that in hump-nosed viper bites, WCT can be more than 20. Then the girl was bitten on paddy field on a rainy day evening. Because of that, we thought it's cobra because it's in cobra bite. There is severe pain and neurological symptoms, not involving car.
But yeah,
That's why we thought.
But you know that envenomation in hump-nosed viper is very much less now, right?
Yes.
Yeah, so because of the way that their flanks are situated, usually envenomation is very, very rare. Right? That's why the whole blood clotting time is normal. Right? So hump-nosed viper, I don't think it's a cobra is the answer. So in that case, they have to mention at least a neurological features to see if I wonder with a rapid bite. Right?
Yeah.
Okay.
Okay, madam. Thank you.
Right. Regarding the preterm infant to term infant, true or false question? At increased risk of intraventricular hemorrhage, true or false?
True.
Yeah. They are at high risk of because their germin layer is very immature, so they are at risk of getting intraventricular hemorrhage, which can lead to hydrocephalus in the later eye. Right? High risk of iron deficiency anemia.
True.
True, because the preterm infants, that iron
Don't have much time to.
yeah, exactly. Right. More prone to vitamin D deficiency, correct?
True.
Yes. Same way is true. You have to because the same principle there. D need higher amount of fluid per body weight. True or false?
Yeah. True.
That is also true because their body surface area is bigger and they are very immature kidneys and water loss is more, and then their skin is delicate, so therefore the water through evaporation is again increased, right? And all in all their fluid requirement is high, right? Okay. At risk of osteopenia.
True. Due to poor bone mineralization.
Sensation and the phosphorus.
Osteopenia of prematurity.
Exactly. Osteopenia of prematurity. Regarding childhood development. A, true or false? That's true, right? If premature baby, up to 2 years we do the correction, right? Okay. Afterwards we stop doing that correction, right? Correction means suppose a baby is born 2 months before. That means baby is born by 32 weeks of gestation, right? So then up to the age of 2 years, we give that allowance, right? So we add another 2 months, not add, we deduct 2 months, right? If suppose that the baby is born at 32 weeks of age, does not control the head at the age of 4 months, the chronological age, we know that still the baby's developmental age is only 2 months, right? Likewise, up to the age of 2 years, we give that allowance. Afterwards, we don't give, right? So development occurs in craniocaudal direction. Is it true? Yes, because child first thing in the development is what? The head control.
Head control.
Head control. Then there's a seated position. Then only they start walking. So it's a craniocaudal direction, right? Okay. So developmental below -1 SP for the age defines developmental delay. Right? Correct or wrong? Minus 2 SD, not minus 1 SD, right? So then only it's away from the Gaussian curve, right? It's not minus 1 SD. 2 or more parameters are needed to diagnose global developmental delay. True or false?
True. True.
True. That is true, right? And CHDR is an important to assess the growth in children. That is true, isn't it? Not only the growth, even the development. CHDR gives a nice sort of a charts, no, to mark on. Right, development. I think you wanted to ask about question C. It should be minus 2 SD, not minus 1. Right? Okay. Any questions around this question and any clarifications? Right. So this question, what is your diagnosis? Before, yeah. Primary.
No, secondary transient lactose intolerance.
Yeah. So
Because of diet.
Yeah. What is the new name for that? We don't call it secondary lactose intolerance now. What is a new term you use? Post-enteritis.
Post-enteritis, like.
Post-enteritis syndrome, isn't it?
Yes.
Right? Yeah. So what would you do?
Continue breastfeeding.
So this is a, what advice would you what advice would you give the mother, to the mother?
Reassure parents and continue breastfeeding.
Ideally, yes. Right? So now, yeah. Okay. No. Here the post-enteritis syndrome, right? We know that lactose causes this, but look, this child, right, not dehydrated, right? Sometimes severe lactose intolerance or severe post-enteritis syndrome, we may have to stop all lactose containing food, including even breast milk, right? In severe form of disease, of course, we may need to give total IV fluid for some time. That is different. But here, look at this thing, right? The baby is exclusively breastfed with vomiting and diarrhea for 3 days. He is not dehydrated, well looking, only the perianal excoriation and stool positive for reducing substance. We're a child, right? Okay. So in this, ideally, it should be reassure parents and continue breastfeeding. So in this, as there are two closely sort of close answers here, I would select reassure parents. So it gives everything, isn't it? Rather than saying a continue breastfeeding, right? So when you reassure the parents, you can ask them to breastfeed, right? Continue breastfeeding is correct. You don't need to give any you don't need to give IV fluids or ORS or whatever. Anyway, we are not going to give ORS for 3 months old baby, right? Okay. So,
Madam,
yeah.
if the baby was dehydrated and ill looking with reduced weight, do we have to stop breastfeeding?
Yes. In severe form of, it's an exception. Usually you don't get it like that. In a severe form of prolonged post-enteritis syndrome, right? The child is severely dehydrated and you can't stop this osmotic diarrhea, you can't stop this osmotic diarrhea, you temporarily withhold, right? You temporarily withhold breast milk, right? But still you don't give lactose-free formula, right? And you give IV fluids, right? For 24 hours or 48 hours to recover and then restart the breastfeeding. Understood? That is the exception. Here the baby is not dehydrated, is well looking. Only problem is the perineal excoriation and stools to the substance positive. Here the well baby, you continue breastfeeding and reassure parents, right?
Okay, madam.
Any questions on this? What is the answer here? Term baby, the low birth weight term baby present with pallor. Mother's blood group A positive, baby's blood group O positive. What is the hemoglobin is 10. Reticulocyte count is 5. What is the most likely diagnosis? Shall we exclude the possible the things first? What are the things that which can be excluded? Could this be physiological?
Iron deficiency.
Iron deficient anemia? Can we exclude?
No.
Baby.
Yeah, term
Yes.
baby. Mhm. Here there's some problem in the question, right? So term
I think, madam,
yeah. What is the answer?
if the mother's blood
Your
group
is not clear.
was O positive and baby, if the mother's blood group was O positive and baby's was A.
Yeah, I think it has been given purposely. So for somebody who are not very familiar to get confused, right? So that's why they have changed it. Mother is A and baby is O. So ABO incompatibility is unlikely because it comes the other way. If the mother is O positive and the baby is A, of course, yes, right? And here what I would say is that again the stem, there is incomplete stem. So they have not mentioned at what day they have found this baby's pain, right? At birth or later, right? So there's one deficiency of that, right? And then the reticulocyte count, 5% means it normal or abnormal? It's
high.
well, in a baby at birth, right? Up to reticulocyte count up to 7 is normal.
7 is
Right? So there is no evidence of hemolysis, severe hemolysis, right? So therefore, I would say this is most likely as a fetal-maternal hemorrhage. Baby is pale and low hemoglobin because the mother's blood group is A baby, so we can safely exclude ABO. We can exclude iron deficiency anemia. Iron deficiency anemia won't happen at birth. And physiological anemia, right? So G6P deficiency, we don't know is a boy or a girl. and at the same time, the reticulocyte count is not that high. So, therefore, I would say it's just a fetal-maternal hemorrhage, right? So, before the baby is born, there's some sort of a hemorrhage occurs, which has led to allow. Okay.
Okay.
I think this stem is not that complete, right? Okay. So that's how you have to think about. ABO is unlikely because the mother is A. Okay. Reticulocyte count is 5. And if this occurs in a term baby at the age of 6 weeks, of course, my answer is physiological anemia. Right? So they have not mentioned on which day they found this patient's hemoglobin of 10. At birth, of course, is abnormal, but at the age of 6 weeks in the term 2.5 baby, at the age of 6 weeks, the hemoglobin of 10 is normal. I would mark it as physiological anemia. And therefore, it's very important at what age anemia is noted is important, right? Understood?
Yes, madam.
This is again an easy question. What is the answer?
DPTA.
Yeah, the POG obstruction, the TTPA is the investigation to see whether there is any obstruction to the outflow tract. What about this question? A 10-year-old male presented with a generalized tonic-clonic seizure for 30 minutes. Seizure was controlled after administration of IV budesonide. He was diagnosed with epilepsy at the age of 8 years and was on sodium valproate for 2 years. There was no seizures for the last 2 years. What would be the next management option? What is the answer?
For the past 2 years, the boy was okay with the drugs. Because of that, revised sodium valproate dose is the
Yes, very likely they were because there's no seizures for the last 2 years. The drugs must have not been revised, right? There will be so as there's a breakthrough conversion. The best thing is first the revised dose of the same. The monotherapy is the best, right? We don't need to do another EEG because this child has already been diagnosed having epilepsy and on treatment and had a good control. Probably the doses are not enough. That's why the breakthrough conversion occurred, right? We don't start carbamazepine till we increase the maximum dose of sodium valproate first. So we revise there's a best response is revise the dose of sodium valproate and see, right? Okay. A 10-year-old boy presented with cough, high fever for 10 days with recent onset retrostomal chest pain. He is ill and has increased work of breathing. He has inspiration stridor. Chest X-ray is unremarkable. What is the most likely diagnosis? What is the answer? What is the answer?
Bacterial tracheitis.
Yes, bacterial tracheitis. Why do you say so?
Because he is ill and increased work of breathing. The cough and high fever lasted for 10 days. because of that, and the thing that there is recent onset of retrosternal chest pain, we thought it's
That is, yeah, that is the only reason why we have said tracheitis. There were all other bacterial tracheitis, epiglottitis, and retropharyngeal abscess and croup. All causes croup. All causes stridor, right? And croup usually does not cause a sort of the child is not toxic, right? And bacterial tracheitis and epiglottitis and retropharyngeal abscess are again left with. But retrosternal chest pain is the key point here to say it's a bacterial tracheitis rather than epiglottitis or retropharyngeal abscess, right? Okay, so all conditions here causes stridor, right? So croup causes harsh stridor, retropharyngeal abscess, epiglottitis and bacterial tracheitis causes very soft stridor. Features of acute life-threatening asthma, pulses, paradoxus is true. That's what you want to ask, no?
yes, madam.
Okay, it is true.
But it's not always true, neither, madam.
Why do you say so?
In some in some patients, we cannot see pulses, paradoxus.
Exactly, yeah. When you are answering questions, you have to, this is a common thing. So features of acute life-threatening asthma, even in, it occurs in 1 or 2 patients, is known in severe acute severe asthma. It should be true, right? Always right? So then when you don't sort of try to sort of analyze this more, analyze the question more, then you will be in trouble. Right?
Okay, madam.
The same question been repeated, I think, in the primary after analysis. Features of systemic AIA include hepatosplenomegaly, true? That is true. Maculopapular rash. It's a palpable maculopapular rash is correct, right? You can feel it also. Yeah. Tender hepatomegaly is wrong. Positive rheumatoid factor, true or false? It's false, isn't it? In children with rheumatoid arthritis, a very, very small proportion of children is rheumatoid factor is positive. That is a polyarticular type of JIA only, they get the positive rheumatoid factor. Others, the rheumatoid factor is negative. What about uveitis?
Oligoarticular.
That is oligoarticular type of JIA is a complication. The uveitis is a complication of quasi-articular type of JIA, not the systemic type of JIA. Okay. Again, same question. What is the answer? Yeah. What is the diagnosis?
Acute renal failure.
Why?
Because
yeah, okay.
Because the boy was already on IV fluids,
yeah,
but having low urine output during last 18 hours.
Any other possibility?
No. With encephalitis.
With encephalitis, what happened?
SIAD.
They can SIADH, isn't it? Right? They can develop SIADH, that inappropriate ADH secretion, so which lead to the retention of water and reduce the urine output. The child is otherwise normotensive and bladder was not distended, right? So it's very likely this oliguria is due to increased secretion of ADH, inappropriate ADH secretion, isn't it? Right? So here the answer is not that, yeah, right? The best answer is here is the serum sodium. Right? It's not written here, right? It will be the best answer. Otherwise, the blood urea, because hemodilution can be checked by checking the blood urea also. Right? Here, the diagnosis is inappropriate ADH secretion. The best indicator is to do the sodium and finding that there is low sodium, then your diagnosis is confirmed. Right? Okay. Any questions on this? What is the answer for this?
We were having trouble of choosing systemic JIA or Kawasaki disease.
Yes. Right? Kawasaki is, yeah, glandular fever, AML, ITP is out. Right? So how would you diagnose whether it's a JIA or a Kawasaki? Right?
But in they haven't mentioned about joint pain, so we took it as Kawasaki.
Just see whether all the criteria is fulfilled to diagnose Kawasaki. Yes, fever more than 2 weeks, right? So has he got lymphadenopathy? So can you tell me that the criteria are fulfilled? Fever more than 2 weeks is there. What else? So,
Maculopapular rash,
yes,
because polymorphous rash,
yeah.
and cervical.
Cervical influence.
No lymphadenopathy, yes.
Right? And so I would select systemic JIA in this patient. Right? Platelet count is high. With the fever of 2 weeks, platelet count has not been increased even. ESR can be high in both conditions, right?
Madam, can this be due to glandular fever?
But granulocytes, 84% granulocytes. And how come the ESR is such high in glandular fever? Right? And the hepatosplenomegaly is not a clinical feature of Kawasaki. Right? Okay. So maculopapular rash. Right? Always the diseases which is diagnosed by using criteria, please check whether those criteria are there to diagnose. Understood?
Yes.
If criteria and fever more than 2 weeks then and high ESR, that's all. And a maculopapular rash. Not enough, ne?
Yes, madam.
Yeah, hepatosplenomegaly is not a feature of Kawasaki. It's a feature of systemic JIA. This kind of a thrombocytosis can occur in even systemic JIA.
But madam, they haven't mentioned about joint pain.
Yes, sometimes it's like that. Joint pain appears later in the disease process, right? Just read your textbook, right? Nelson's read. Sometimes these patients will not present with any arthralgia. That is a known factor. Right? Known fact. Right? So,
okay.
Yeah, it's not be apparent at the beginning. පොතේ බලන්න අච්චු පොතේ තියෙනවා. නෙල්සන් එකේ හැම කියලා තියෙනවා. මට පරණ මතකයක් නෑ දැන් අලුත් පොතේ තියෙන්නේ නැහැ. එහෙම තියෙනවා. Right? Okay.
Okay.
Physical signs in respiratory system include stridor indicates obstruction above the vocal cords, correct or wrong? No, wrong. Here I won't say it's wrong, right? But it does not only indicate the above vocal cords, because sometimes the bacterial tracheitis is below the vocal cords, right? Usually stridor indicates the upper respiratory obstruction. In that case, the vocal cords, above vocal cords is also correct. If this says like this, stridor indicates obstruction, only obstruction above the vocal cords is wrong. But here this stem is, I would mark it as correct, because most of the reasons of stridor is the upper respiratory, this thing, so above trachea, not above vocal cords, right? Barking cough is seen in group. True or false?
True.
True.
True. Yes. Grunting is in expiration. Is it correct? Grunting is what? Forced. Expiration against closed glottis.
Glottis.
Right? So it's correct. Grunting occurs in expiration. That is a sound, right? So in order to maintain the high PEEP,
Positive air.
positive airway pressure, right? The grunting occurs in expiration. Increased vocal primitus present in lobar pneumonia. True or false?
True.
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 E. Pleural rub present in massive pulmonary effusion. Is it correct?
True.
True or false? Pleural rub occurs in massive effusion.
False.
That is false, because when there is the two pleura should be close together to get a rub, right? In massive effusions, they seem far away, right? So it's common with the small effusions and rare with the massive effusions. So what is the diagnosis here? I think the stems are not correct here, right? What is the diagnosis?
Congenital.
Yes, go ahead. Congenital.
Adrenal hypoplasia.
Why do you say so? Hyperpigmented scrotum is a baby who presently poor feeding, and in examination only the hyperpigmented scrotum, right? The full blood count normal, and here
Sodium is low in potassium.
low sodium and high potassium, right? So what would be the next investigation that you would be doing?
17 alpha.
Yeah, here that the question, please read the question properly, right? What would be the next investigation? That I would do a blood gas analysis, right? Or I would do a random blood sugar, because hypoglycemia is a feature, acidosis is a feature, right? But we will not be able to confirm the diagnosis. To confirm the diagnosis, I need to do 17 OHP, right? Right? Confirm the diagnosis, you need to do a 17 OHP. But for others, the next step would be a blood gas analysis or a blood sugar. Right? They get hypoglycemia, they get acidosis. Right? What is the answer here? What is the diagnosis? This is rickets definitely. What is the type of rickets? In what kind of rickets you get? High phosphate. Rickets, the biochemically you get increased alkaline phosphatase. In nutritional rickets, what happened? Calcium is maybe normal or low, and phosphate is normal or low. Sorry, phosphate usually low. What is the condition where the phosphate is high, which is associated with rickets? It's chronic renal failure, right? That is the only time that you get high phosphate with rickets, right? So request serum creatinine, answer is the request serum creatinine level, right? It is not nutritional rickets. In nutritional rickets, phosphates levels are low, right? Okay. So we have to exclude renal failure here, right? Okay. In the assessment of hematuria, hypercalciuria is a recognized cause. Yes. Hypercalciuria is one of the common cause for microscopic or macroscopic hematuria or recurrent hematuria. That is a common cause, right? Familial hypercalciuria can lead to recurrent painless hematuria. Family history of deafness suggests IgA nephropathy. True or false? False. Alport syndrome is the, to confuse you, they have put it, right? IgA nephropathy is wrong, but Alport, of course, yes, right? Coexistent proteinuria makes a renal parenchymal problem more likely. Is it correct? A child who presents with hematuria, the presence of proteinuria, what does it mean? Involvement of the glomeruli, right? So then this stem is correct. Coexistent proteinuria makes a renal parenchymal problem is more likely. That is true. Renal tract ultrasound scan is essential. Correct or wrong? Yes, that is true. That is true. In hematuria, right? Hematuria, you got to find out whether, right? You got to exclude stones and all, right? So, ultrasound scan of the abdomen is a first-line investigation in hematuria, right? It's a first-line investigation. Each and every child who presents with hematuria, right, or recurrent hematuria, right? Not that this is post-streptococcal hematuria, right? Hematuria, then you got to do ultrasound scan. Measurement of C3 is not usually helpful. True or false? True or false?
True.
That
Then
is
we
true. Yeah. So if this hematuria is due to
post-streptococcal glomerulonephritis, it should be low.
So yes. So that is important, right? To find the glomerular causes or non-glomerular causes of hematuria. Okay. Dysuria is a feature of balanitis. True or false?
True.
Pyelonephritis.
True. False.
True. Pyelonephritis is false. Most of the time they won't present with dysuria. Right? Perennial candidiasis, true or false?
True.
Renal stones,
True.
true, because any kind of a high concentration of calcium and carbonate can cause irritation of the urethra, can lead to increased frequency and dysuria. Pinworm infestation,
True.
it is true. Pinworm infestation and those pinworm can migrate or sometimes causing itchiness, which leads to dysuria. These are general terms, right? See, UTI screening school children for UTI can prevent CRF. True or false?
False.
False. And we don't screen, and by the time that the school children, we will not be able to stop the process of damage in the kidneys, right? Associated renal pathologies contribute for renal damage. True or false?
True.
That is true. UTI associated with fever and vomiting needs IV fluids and IV antibiotics immediately. True or false?
True. True due to pyelonephritis.
With fever and vomiting.
Systemic
Involvement, but they have not mentioned the age, right? That is important to mention the age, right? UTI constipation is a causative factor. True or false?
True.
That is true. UTI high fever indicated pyelonephritis. True or false?
True.
That is true, right? Associated antibiotic immediately, that is of course not always, right? That depends on the age of the child, right? Okay.
Okay.
Right. So this is again a true or false question. Same A, true or false?
True.
That is true. Even in the acute case, true. Right? Anyway, post-operative disease occurs after a few weeks after infection. Right? Stem B.
False.
That is false. Concerning post-operative arthritis, most of the time beta hemolytic streptococci are the organism. Right? It's not a non-hemolytic streptococci. Beta group A beta hemolytic streptococci is the cause for post-operative infection. Hypertensive encephalopathy is a recognized complication. True or false?
True. True.
Yeah. And the treatment with penicillin reduces the time of course of the illness.
It's just for the prophylaxis.
It's not, you don't call it as a prophylaxis, but to eradicate the already happened organisms, right? But it does not reduce the time course of the disease because the injury has already happened, right? It usually occurs in children under the age of 2 years. True or false?
False.
That is false, right? The disease of a preschoolers, isn't it? Okay. Right. That's all for today, right? Because so I think discuss about the 50% of MCQs that you have sent, right? I'll see whether I would be able to arrange somebody tomorrow, right? Do you think this is important and effective, or do you want to discuss all? Because tomorrow If I am not here, probably I have asked Dr. Aruna, he said he is also a bit busy. I'll find somebody to discuss, right? Okay.
Okay.
Okay, madam.
So here we are. Present of the institute that you have sent, I have discussed today. Okay. Okay. So now it's 10:30, 10:35. Right? Okay. So try to go study around the MCQ. It's very important. And in single best response, always try to exclude things first and get the one of those things and then decide what would be the best answer, right? Okay, when you're marking, right? Okay, so shall we wind up now?
Okay, madam.
Okay.
Okay, so good night.
Thank you. Good night, madam.
Thank you, madam.